Hormone replacement therapy is never far from the news. It seems that almost daily we get conflicting reports in the media about HRT. One day it's safe, the next day it isn't. All of this can be terribly confusing for women when they're going through that natural menopause transition. I'm with Dr Vikram Talaulikar from the Menopause Clinic in London, who's going to talk to us about HRT, what, if any, are the pitfalls and the risks, and more importantly, what are the benefits. So, Dr Talaulikar, what exactly is hormone replacement therapy and when would it be recommended for a woman?
Hormone replacement therapy refers to replacement of three hormones. The key hormone being estrogen, the second hormone is progesterone, and the less talked about hormone, which is testosterone. Hormone replacement therapy is basically indicated for suppression of symptoms of menopause. This is hot flushes, night sweats, sleep disturbance, changes in hair, nails, skin, lack of libido, lack of energy, also sometimes other symptoms such as bladder symptoms or vaginal dryness. All those are the key symptoms that a woman will experience as she goes through menopausal transition. But it's not just about symptom suppression. It's also about planning the long-term health and the long-term health benefits. So we know, for example, that estrogen protects against bone loss. We know that estrogen has some implications for prevention of dementia, although more research is needed in this particular avenue. Also, estrogen between the age of 50 to 60 often gives cardiac or heart protection to women. So it's about the long-term health benefits.
So what are the different forms of HRT?
So HRT can be administered in different ways. Traditionally, HRT was always administered as oral tablets. But over the last couple of decades, there have been so many changes in the way hormones are administered. Today, most of the practitioners like to give HRT in non-oral methods. So to say that estrogen can now be administered as oral tablets, can be administered as transdermal therapy in the form of skin patches or gel applied on the skin. It can also be administered as implants, which are inserted in the subcutaneous tissue, fat beneath the skin. Estrogen is also available as pessaries or creams, which can be administered vaginally. If you look at progesterone, it can again be administered as tablets. It forms part of the patch. It can also be administered as a coil, which can sit inside the womb. You have got testosterone, which can be administered as a gel, or you can also have implants, which can be inserted in the fat layer beneath the skin. There has been more and more change in terms of administering HRT as transdermal patches or gels or coils or implants over the years, simply because we know that they have less risks or long-term side effects associated with them as compared to the traditional way of giving HRT, which was oral tablets.
Thank you. The different types of HRT, you talked very much that estrogen was the dominant, and when people were thinking about replacing hormones, we think primarily of estrogen. But are there different types, different combinations of HRT?
Yes, Katie. So HRT is usually looked at as a combination of estrogen and progesterone. We now know that women produce a lot of testosterone before going through the menopausal transition. So when I talk about HRT, I will always talk about estrogen, progesterone, and testosterone. Traditionally, the HRT combinations have always included an estrogen with something we call as a synthetic progesterone. And synthetic progesterone is more appropriately termed as progestogen rather than progesterone, because it's not same as the natural hormone the body produces. Over the years, we've now moved on towards body-identical hormones. So that is a combination of estrogen with natural progesterone. These hormones are like for like. These are the ones that would normally be produced by the body. It has been found that body-identical hormones, both the estrogen and the progesterone, have less risks if they are used long-term for health protection or for symptom suppression, as compared to the synthetic hormones, which used to form part of the traditional or conventional HRT preparations. I must make sure that I also clarify what bioidentical means and body identical means, because that's one of the stories which has been quite widely covered in the press recently. When we talk about body identical hormones, these are hormones which would be similar to that produced by the body naturally. Although they are derived sometimes from plant sources, these have been robustly tested by pharmaceutical companies or other scientific institutions. So they have quite a bit of scientific evidence that they are efficacious, but at the same time they don't carry undue long-term risks. Bioidentical HRT, on the other hand, is different. So these are custom-made preparations by individual clinicians or clinics. These are basically a mixture of different forms of estrogen, progesterone. Some of the forms, for example, are pregnenolone or estrone or estriol, which are combined with natural hormones. And so we do not know what the long-term safety or the efficacy of these preparations is. So recently, the British Medical Association, as well as the BMS, which is the British Menopause Society, have come up with a statement saying that such preparations or combinations which have not been rigorously scientifically tested are not being recommended by these societies, and it's important that we make that distinction between body identical natural hormones and plant-based non-formulary preparations which have been formed by individual clinics.
Thank you, that's really helpful, because I know there's been a lot in the press about bioidentical hormones and there's a lot of confusion about that. So that was really helpful to clarify that for people. You mentioned some of the risks associated with HRT. There is a lot of scares with women out there that HRT causes breast cancer. Could you actually help to clarify what is the truth behind that statement?
Thank you for asking me that question, Katie. That's one of the most important questions in terms of risks of HRT. If there's one reason why most women are hesitant to go and have HRT, or there's one reason why GPs are not keen to prescribe HRT, it is the risk of breast cancer. And we know that when the big studies came out around 2002, 2003, there was quite a bit of a discussion in terms of the HRT causing breast cancer, which then led to a complete decline in prescription of HRT. However, the results of those studies have been reanalyzed, and we know that those risks were exaggerated. The population which was then studied as part of those studies was not the same population that we now often recommend HRT to. And so therefore we have to look at the breast cancer risks in relation to HRT with a completely new perspective. And you can see that the recent NICE guidelines do exactly that. They've looked at the evidence, reanalyzed the results, and find that the evidence says that the risks are nowhere close to what they were publicized in 2002 or 2003. If it would be easy, I would like to take help of a figure diagram that might just make it easy for me to explain some of those risks. So we look at the figure here, which shows the baseline risk of developing breast cancer or a breast cancer diagnosis in women who are between 50 to 59 years old. If they used HRT for 5 years, then what would be the additional risk of developing a breast cancer? Now, that figure shows you the baseline risk in women in general population. So if there were 1,000 women between 50 to 59, they were not using HRT, and they were going about their daily lives, how many of them would develop a breast cancer? So about 23 out of those 1,000 women would receive a diagnosis of breast cancer. This may be linked to their genetic background, this may be linked to their lifestyle factors, many other issues. But that's the general background risk of developing a diagnosis of breast cancer. Now let's put that into perspective and compare it against some of the common lifestyle factors as well as some of the reproductive factors. So that line there shows you the baseline risk, which we know is about 23 women out of 1,000 women. Now let's look at each factor and how it would affect the risk of breast cancer. So we first look at smoking. You can note that a woman who is smoking, there will be about 3 extra women in addition to the 23 women who would develop a diagnosis of breast cancer who would then get a diagnosis of breast cancer. So that's extra 3 women developing breast cancer if they're smoking. Compare that to a combined HRT, which is basically a combination of estrogen and progesterone for 5 years or more. It would be additional 4 women who would be given that diagnosis. If you look at women who drink 2 or more units of alcohol, it would be extra 5 women in addition to the 23 women, so that's 28 out of 1,000, who would get a diagnosis of breast cancer. The big one, if you move down to the BMI and look at that huge increase in risk, so that's almost extra 24 women out of 1,000 who are now getting a diagnosis of breast cancer. So that's double the baseline risk. If you compare those, HRTs is far, far back as compared to the BMI risk. But the good news is that if you look at the last 2 categories, where women who take only estrogen-only HRT, so they've had a hysterectomy, they've had their womb removed, and so only need estrogen, they don't need the other hormone, the progesterone, they actually seem to have a lower risk of breast cancer. So that's -4 less cases of breast cancer out of those 1,000 women having the HRT. And the same thing for exercise. It's fantastic. So you have 7 less women developing a diagnosis of breast cancer if they were doing about 2.5 hours of exercise a week. So those two seem to be protective factor almost as compared to some of the common lifestyle factors which have a far, far higher risk of the breast cancer diagnosis. So to put it into perspective, if you look at all these lifestyle factors, one would say, is HRT really a big risk for breast cancer if you compare it to other lifestyle factors? It's for each woman to decide that. But most women will find that the risk coming from HRT is actually far less as compared to some of their day-to-day lifestyle factors.
Fantastic. Really interesting you talk about the risks with breast cancer, and you mentioned that with combined HRT, so that's with estrogen and progesterone, it may go up by 4, so to 27 out of every 1,000 women. Does the type of HRT or the type of progesterone prescribed in that HRT preparation make a difference?
Yes, indeed. So progesterone looks to be the hormone that contributes to the excess risk of breast cancer. Traditionally, people thought that estrogen and progesterone both have a risk. As we've reanalyzed the data, we've got more and more well-performed studies which have given results. We now find that it is the progesterone which is the culprit. And so that brings in the risk of breast cancer. We now know that synthetic progesterones, or progestogens as they are called, which were part of the traditional HRT preparations, often do increase the risk of breast cancer. But if you compare that to natural progesterone or body identical progesterone, in the UK it's widely the Utrogestan, that has the minimal risk of breast cancer. So out of the two, it is always better to use natural progesterone as compared to the synthetic progestogen. The other way to minimize the risk is the time of taking progesterone. For example, you may decide to administer progesterone once every 60 or 70 days instead of giving it every day as part of bleed-free HRT or every 12 or 14 days of each cycle, so that you limit the amount of days that the progesterone is administered. This way you can again reduce the amount of progesterone that gets into the body, and that would mean there is lower risk of breast cancer. Even better is to administer progesterone as a Mirena coil, which is inserted in the womb. This has an advantage because the progesterone from the coil is only absorbed from the womb into the lining of the womb, and very, very little is actually going into the rest of the body. And so therefore, for majority of women, you will find that the levels of progesterone which are achieved with a coil are far less than giving progesterone as a patch or a tablet. That again would minimize the risk of breast cancer. So there are ways to get around the progesterone causing risk of breast cancer.
That's really helpful, thank you. Because a lot of women think there are huge risks with HRT, so to have that put into perspective and have those risks allayed is really, really helpful. So can you talk to us about what are the benefits of taking HRT for women? How does it help them? And do women have to be struggling through the menopause in order to request HRT from their GP?
So Benefits of HRT are huge. First of all, it is about the symptoms. Many women struggle through menopausal transition. A large majority will be fine, but about 25% of women really struggle through the transition. And in our own experience, HRT can transform lives. HRT given at the right time, in the right dose, in the safest possible route, will often suppress most of the menopausal symptoms. It will improve the sleep pattern, give higher energy. It will improve mood. Many women have heightened anxiety. It will often suppress that. Hot flushes, night sweat should disappear. Vaginal dryness should be taken care of. So almost all core symptoms of menopause will improve. That would mean that general quality of life will improve. That's mainly the treatment aspect of HRT. But the long-term health benefits are equally important. So we know that women under 60 who start HRT early in their life will often have benefits for bone. They are less at risk of developing osteoporosis because estrogen gives bone protection. Although studies are ongoing and it's not conclusive, we know that estrogen is beneficial for brain and cognitive function, and it may have a role in prevention of dementia. We also know that estrogen administered between 45 to 60 does lead to less risk of heart disease after 60. So there are plenty of long-term health benefits in addition to the symptom suppression. And of course then the testosterone, which is often important for muscle mass, for bone health, for libido and sexual function, which forms such a critical aspect of quality of life. So all in all, there are plenty of health benefits as well as overall benefits of symptom suppression.
If a woman is taking the right combination, the right type of HRT, and she remains healthy and gets checked regularly, is there any need for her to stop taking it, or is it safe for a woman to continue to take it?
Well, there is no upper limit now to when HRT should be stopped in terms of women's age. Traditionally, the view was administer HRT for the shortest period of time at the lowest dose possible. And this was really when there was a scare about HRT causing breast cancer or stroke. We now know that we've got so many different varieties and routes of administering HRT. We've got the natural hormones, and so those risks are minimal. If the woman stands to benefit, both in terms of symptom suppression, good quality of life, and the long-term health, then I see no reason why a woman would want to stop HRT at a certain age, just as a number. It would really be important to assess her benefits and her risks on an ongoing basis. Usually what we say is an annual review to make sure that the benefits outweigh any potential medical risk, but there should be no upper age limit strictly to how long one can use HRT.
Thank you so much for your time, Dr. Talaulikar. That's been really, really helpful. There is so much confusion about HRT out there, and I know with the workshops that we run, to just get that reassurance from somebody who knows and sees women every single day is going to be hugely reassuring for them. So thank you so much.
Thank you.